Hello, and thank you for inviting me to the FAI Summit 2021. Thank you for taking time to listen to my presentation. My name is Danilo Contiero, and I am the president of the Functional Aging Institute in Europe. I'm also a PhD candidate at the University of the West of Scotland, and I'm an assistant researcher at the University Hospital Federico II, Department of Sport Medicine, and the Laboratory of Adapted Physical Activity in Naples, Italy. What I will talk to you about today is the exercise professionals in the clinical environment, a European perspective with a focus on sport and exercise science. Why I'm talking about this, as you can see, is not it's not a presentation based on the health benefits of physical activity as most of the other ones, because first of all, I'm sure there are many other presentations related to this topic, but also because I would like, since the FAI Europe was born, I would like that also in the USA you get an idea of how it's changing in Europe the world of fitness, and how it's coming up a new path that is closer, much closer to the clinical environment than to the fitness industry per se, and where and how these two paths are connected, and they're working together, and how the FAI course of FAI specialist, functional aging specialist, can be the link between the clinical path and the fitness path related to sports science. There is a bit of chaos here in Europe because there is not a real job that specify what is a sports scientist, what is a personal trainer, or a fitness specialist. So after you get graduated in sports science, you really don't know what is your path. And I think this is for us that live in Europe one of the most unanswered, frequently asked questions. First question is, are we alone in the universe? Was the egg or chicken first? And third question is, what is the job after you graduate in sports science in Europe? Because as I was saying, as you know, once you get graduated, then you don't really have a proper career. You're not a clinical professional. And to work in the fitness industry, you don't really need a degree in Europe. You just need a PT course in the best scenario. You can even not need that. So what is the future of you that get an education in sports science, or that get educated at high level with high courses as the functional aging specialist? I'm here to try to answer that. Let's start from what is a sports scientist, who is a sports scientist, and what people think a sports scientist is. In fact, there is a general misconception, general population, about sports science per se. And usually, general population thinks that sports scientists are personal trainer, physiotherapist, physical therapist, masseurs, or sometimes they don't even know what sports science is. They don't even know it's a faculty. And believe me, I can tell you this happened really often because I follow this academic path, and many times when they ask me, what do you study? And I say sports science. These are real answers that have been given by people. On the other side, other clinical professions as physiotherapists consider us as enemies, as a threat, because they think that we are going to take their slice of the market. And so they consider us as poorly educated people or as useless profession, because they don't want us to be recognized as a clinical professional, to avoid that we take some of their clients. But if they will know better sports science, they will understand that actually we are not aiming at the same slice of the market, or better, we are aiming at the same slice of the market, but to offer a different service. So there shouldn't be reason to consider us in any way as a threat. And what the government thinks of sports scientists, well, is just they think of us as PE teacher, physical education teacher. So as you can see, while abroad you have different paths. If you want to become a kinesiologist, if you want to become a PE teacher, if you want to become a sport coach or physical therapist, in Europe and mostly in Italy, we don't have that. So the only faculty that we have is sports science, and everybody gets there. Who wants to be a personal trainer, who wants to be a fitness manager, who wants to be a PE teacher or a sport coach. Doesn't matter. Everybody goes there. And so after you graduate, you don't really know what you have to do because there are many options, but no option is a real profession. So, who is really a sports scientist? Let's try to give a definition. I'd like to consider sports scientist as a fitness professional who has been educated at the bachelor or master of science level. And what actually sports scientists do is to work in the fitness industry, but also supervising health and sport related activities. It doesn't mean only personal training, but includes as well personal training, but also sport coaching, sport development, well-being, and so on. And sport scientists very often academic researchers too, and they don't research only in sports science, but also in health-related fields as public health, prevention, rehabilitation, clinical exercise, quality of life, and even sometimes research is related to social studies that involve quality of life, social inclusion through physical activity. So, what is happening now in our days? Sport and exercise science is becoming always more relevant in public health. After many years of research and many data that have been published, science cannot deny anymore the importance of being physically active and the importance of physical activity for a healthier lifestyle and longer life. At the same time, governments have to give some new guidelines, and not only governments, but even health organizations, the World Health Organization, claiming that it's necessarily to respect some amount of physical activity per day in order to avoid the risk of sedentary that is related to high risk of mortality and morbidities. And on the other hand, we have medical doctors that starts to be even more passionate about sports science and starts to consider it as a real drug. They start to consider physical activity as a real drug able to prevent, treat, and slow down some serious illnesses, as much as other famous and other traditional drugs that we find on the market. So physical activity is not a pill, but can be treated as a drug as well. But anyway, nevertheless, we have all this success in science, and from the perspective of new medical doctors, um, exercise scientists, sports scientists, are still not considered as a true recognized clinical profession. And it is raising uh, the need to involve fitness profession in clinical environments following the research and the last data that confirms that the benefits of physical activity on people suffering from chronic conditions and just on people that are trying to prevent some chronic conditions. So there is this general changing considering that general population starts to be aware of the fact that being sedentary is dangerous for health, is not good, but they are not really aware of the benefits of the physical activity. So they know that it's bad to sit on the chair for all day, but they don't know how good it is for them to have a walk or a certain kind of physical activity at that intensity for that amount of time. So how do we start to use exercise as a drug, as real medicine? We can start to use physical activity or physical exercise as a drug to prevent or treat diseases, syndromes, and symptoms for which we have no other medical treatment. Let's consider, for example, sarcopenia. We have no pills that stops or reduce the risk of sarcopenia, but physical activity and physical exercise can do that. We can use physical exercise as substitute for less effective or more hazardous forms of treatment. We can use it to amend the effects of other available preventive or treatment strategies. And we can use it as offset the side effects of current treatments and to counterage related changes in physiology which pose risk factor to morbidity and mortality. So there are many cases in which we can use medicine as a drug. For example, I said before about sarcopenia, but even for mental health, the American Psychiatric Association started to prescribe physical activity together with other medical treatment as one of the first steps to prevent depressive symptoms and to treat depressive symptoms. Sorry. At the same time, when we age, we meet some obvious physiological change, but these age-related changes cannot be usually slowed down or prevented by chemical drugs. But physical activity instead can help us to age better, to age younger, more active, and live longer. Here some few practical examples of research related to sports science. Here we consider the effects of high-intensity progressive resistance training and targets multidisciplinary treatment of frailty on mortality and nursing home admission after hip fracture, a randomized control trial. This study was performed by Nalin and colleagues, but among the colleagues, I think it's very important to name Professor Maria Fiatarone, which is a geriatric enrolled at the University of Sydney, and she has dedicated almost all her life to study the connections between physical activity and elderly. And basically, we have always thought, at least until a few years ago, that training was dangerous for older adults. But then scientists as Maria Fiatarone led research showing that it's actually not true at all, and that muscle can respond even at a later age, after the age of 70 or 80. And therefore, there are more risks for older people not doing physical exercises than if they would do some physical exercise. And they started to create some programs to introduce physical activity in nursing homes, and the results are very, very surprising for the benefits that physical exercise, physical activity brought to the patients of the nursing homes. Here you can find table of contents with the intervention component, the proportion prescribed, and the screening tool of the previous study. But let's consider also one of the most popular illness related to later life, which is osteoporosis. Until a few years ago, not a few years ago, but until a while ago, we used to think that people suffering from osteoporosis were actually in danger if they were practicing some physical activity of a certain intensity. But actually, the guidelines of the osteoporosis associations in Australia suggest that people that already have osteoporosis or that are at risk of osteoporosis should practice progressive resistance training 2-3 times a week with a moderate vigorous intensity. And this will help not only in the younger adults to slow down the loss of bone mineral density, but it will also help to build a stronger muscle structure that will help the lack, that will compensate the lack of the bone mineral density. Physical activity, as I said before, is not only necessary for the most visible physiological functions, but it can also help to reduce the risk of dementia. Dementia is one of the other most common illness related to later life, and physical activity has been proved to reduce the risk of dementia of the 18. As we said before, we talked about sarcopenia, and there is no pill effective for sarcopenia, but what we have is physical activity, and as you can see from the picture on the right, the muscles physiology changes very much in later life, even in very elderly subjects, after practicing some strength exercises. And this is the best way to best and probably the only way to prevent and slow down the process of. So, very well aware of this knowledge, at the university hospital, Professor Guido Iaccarino decided to start a pilot project called Adapted Physical Activity, or Attività Fisica Adattata in Italian, under the name of AFA. The aim of this project is to involve both sports scientists and medical doctors to work together, trying to prescribe exercise as a real drug. The goal is to improve people's quality and length of life, reduce the risk of chronic disease, promote social inclusion in later life, reduce the cost of public health, and help patients to recover faster from accidents or from serious injuries. Or how does the FAA laboratory work? So basically, when a patient steps in, the first thing we do is an anamnesis, and this is performed usually by a medical doctor. During this anamnesis, we try to understand what's the clinical history of the patients and of the family. If there is some familiarity with previous illnesses, or there are some genetic conditions that can affect our next steps. Then we perform some fitness tests that we show you later, and then the BIA exams to have a better idea of the body composition, and this is usually performed by a medical doctor or a sports scientist. And then the medical doctors only perform the electrocardiogram under stress. And basically, thanks to these exams, we are able to see how the heart responds to physical stress, or physical or an external stress caused by physical activity. And then after that, both the medical doctors and both the sports scientists discuss together what is the best prescription of physical activity to deliver for the patients in order to prevent or treat a specific chronic. So after that, these people have received their exercise protocol. This exercise protocol is uploaded on an app, and they will be able to see their exercises on their phone at home and try to do these exercises at home. After that, they will be able to come first time for a check after 6 weeks, and then we'll take it from there, according to how things are going. We are able to track patients' adherence to the physical activity thanks to the app, but definitely people miss the training in a class and the social component of collective physical activities. Anyway, in these times of COVID and in these times of necessary isolation, this seems to be a good solution to prevent totally sedentary behavior. So let's give a closer look to the physical assessment to the fitness test. As I said before, we start one of the tests is the ECG, electrocardiogram under stress. Usually we perform this at the cyclogometer or to the treadmill, and this test is determined to understand which kind of intensity the patients can tolerate without going in critical or dangerous health conditions. So this will be necessary for our next step, which is the prescription of the exercise, because we have to be very precise about the intensity and the time that these people can and cannot perform. Then we have the balance test. This test is performed asking the patients to lift up their arms, close their eyes, and to march on the spot. During the march, we will see if the patients will move to the right, to the left, will move forward or backward. And after 30 seconds, we stop the patients and we take the measurements from the starting point. If the subject moves a lot, which means doesn't have very good perception of the space around, and this might affect their balance and expose them to the risk of falls, which is very important if we talk about. Then we have the hand grip test. Thanks to the dynamometer, we are able to have an evaluation of the hands and forearms strength. This is a good indicator for risk of sarcopenia. So, thanks to the dynamometer, we are able to understand if the strength of in the upper limbs is quite good or not, and if it's not, this might expose people to the risk of sarcopenia. Then we have the chair test. Thanks to the chair test, we try to have a perception of the lower limb strength in our patients. This test is very popular and basically is performed by the patients that have to sit down on the chair with the arms crossing on their chest in 30 seconds as many times. And then we have the BIA, thanks to which we are able to evaluate the body composition. So this is more efficient for us to give a definition of patients that needs to change their body composition and it more reduce the fat mass, and increase the muscle mass. This is not only in elderly people, but usually in general populations. An exam is a very popular exam, not invasive, that mostly everybody does today, even if you go to a nutrition. And then we have a little test for the flexibility. This is a lab adapted test. Of course, is not maybe the most the most advanced one, but for what we have, it's quite okay, and help us to understand what is the range of flexibility of the patients. If patients have a good flexibility, well, definitely that's a good starting point. And we will love to make more other kinds of tests, but we are starting with this pilot project, so we're really going step by step, and this is a good evaluation for the beginning to have an idea of what's the ability of the. So what's the FAI Europe fits with this, because the project of AFA starting to develop and starting to develop and starting to get more interest, and has become a real and has a real dedicated master course. This master course is attended by sports scientists, physical therapists, physiotherapists, and doctors. And the FAI is proudly partner of this course because the university has considered the research material of the Functional Aging Institute as necessary as a necessary material to develop more guidelines on the prescription of physical activity for elderly people. So this is a very good satisfaction for the FAI to be considered of such a higher consider such high to receive such high consideration from academic institution. There's also a hospital that trust them as for the education of their fitness experts in the subjects of elderly population. And at the same time, as FAI Europe is developing, we hope that in the next future we will have more fitness enthusiasts and more fitness specialists that would like to take our course. And we hope that in the next future there will be a very good exchange between the people that have been educated with FAI in Europe and people that have been educated with FAI in the USA. And we hope that there could be a connection and a co-working between Europe and the USA. And to do this, I'm sure it's necessary to understand what is the background of the European partners, of the European colleagues, and at the same time from Europeans to understand what's the background of the international ones. So this can help us to work better and to cooperate better in the future. I would like to thank you again once more for your attention at this presentation, and I apologize if some of you might have expected the presentation more related to the physiological, physical benefits of physical activity, but I think that is a topic that you already know quite well, as it's a very, very frequent topic, and many of my other colleagues who have presented today. But I want to share with you how is the experience of the FAI in Europe, what are the steps that we are doing now, and how the idea of fitness is changing in Europe. So we're here now. Fitness is it's like we have one big entry route, which is sports science for fitness, and then after that, from there you can go as fitness coach, sports scientist, exercise physiologist, whatever. And basically what we are observing now is that there is a movement of the fitness much closer to the clinical environment. The sports science is closer to the clinical environment than to the fitness industry per se. So this will be very interesting for the FAI development, and it will be very interesting for you as well. I hope and I think, to understand that there is movement in this direction that I'm sure is happening as well in the USA. So taking part to the FAI, taking the FAI specialist course does not only mean to be a more educated fitness professional, but is also one more step closer to the health and clinical environment. Thank you very much.